Hello everybody, I'm Dr. Ilker Kahramanoglu. Today with my colleague, dear Dr. Esra, Bilir, we're going to interview Professor Nadeem Abu-Rustum, who is an expert on the field. Our questions will be about fertility-sparing surgery. We have a lot of interesting questions. So thank you for sharing your time with us. So my first question will be, what's your view on completion surgery post-childbirth in ovarian cancer patients?
So after completing childbirth and delivery, for patients who have had ovarian cancer, we usually have a discussion about completion surgery. That's been a tradition in GYN oncology. Once somebody's developed invasive ovarian cancer and had the opportunity to maintain fertility, usually once childbearing is completed, we usually have a discussion about completion surgery. And that could be based on the patient's desire, and it's a conversation, but I think it's reasonable to have that conversation.
Yeah, very good, excellent, thank you.
Thank you so much. And I'll continue. How long should the patient need to wait to conceive after the fertility-sparing management for endometrial and ovarian cancer?
So it's different between the two diseases. For endometrial cancer, once you have achieved a negative DNC for cancer or a negative biopsy for cancer, we usually clear the patient to attempt a pregnancy. There's no more time waiting. Some guidelines require 2 negative biopsies, maybe 3 months apart. But for us in practice, 1 DNC or 1 biopsy that's negative would clear the patient. It's different for ovarian cancer because some of these patients may need adjuvant therapy or chemotherapy, but in general, at the minimum, we usually wait 6 months, preferably between 6 months to 1 year. Make sure the patient remains without evidence of disease to clear for pregnancy.
So my next question will be about ovarian stimulation. Is it safe after fertility-sparing surgery for epithelial ovarian cancer?
So that's an important question. There's a lot of debate and controversy, but I think the comfort with ovarian stimulation and egg retrieval has really evolved a lot over the past 15-20 years. We're more and more comfortable referring patients for ovarian stimulation and egg retrieval in a variety of settings where people were not comfortable in the past, including borderline tumors and invasive cancer. So for us, we would see it as a reasonable strategy to meet with reproductive endocrinology and have this discussion and proceed with it if found reasonable.
Great.
And what will be your opinion on the neoadjuvant chemotherapy for the cervical cancer between 2 to 4 centimeters, giving the 20% of nodal metastasis risk?
It's a very good question because there are 2 schools of thought. One would say it's okay to do neoadjuvant chemotherapy. The response rates can be very high and you can abbreviate surgery and have a good obstetrical outcome. The other school would say the data today, if you look at all the data on folks who had upfront neoadjuvant chemotherapy for 2 to 4 centimeter versus those that had radical abdominal trachelectomy, the recurrence data is much more in favor of upfront radical abdominal trachelectomy. Recurrence rate maybe 4 or 5%, and the neoadjuvant chemotherapy group, again we're talking 2 to 4 centimeter, can be maybe 14%. Some data is suggesting even higher. There's an ongoing study led by Marie Plante looking at this question specifically. The study is controlled because before chemotherapy, patients do have imaging plus sentinel node mapping, bilateral negative nodes, and then if they meet those criteria, then they can receive neoadjuvant chemotherapy. So that's an important study and will give us a lot more information. In our department, we think that upfront neoadjuvant chemotherapy without doing mapping is probably not the best way to proceed.
Yeah, very important point, thank you. And we will go with cervical cancer. And $1 million question: if you find isolated tumor cells after fertility-sparing surgery for cervical cancer, should further treatment be avoided?
Yeah, it's a good question. Unfortunately, over the last 20 years of doing trachelectomies for stage 1, we've had patients with ITC, and I have to say, in the past, we did not feel comfortable ignoring those. We felt that if you have isolated tumor cells in the setting of fertility preservation for cervix cancer, some additional treatment should be done. Now, maybe we are overreacting, maybe we are over-treating, but that's what we have done. We have been very conservative to take absolutely the safest criteria to allow somebody to proceed with uterine preservation, etc. So it's an open question. We need more data on that.
So in your practice, how do you manage these cases?
It's managed case by case. I usually would tell patients you have isolated tumor cells. If patients, and many patients have made a decision that they will take some risk, and if they want to continue, then we will observe them, we will image them, we will monitor them. But I also have to have a conversation with the patient that ITCs in the setting of cervix cancer may carry some risk of recurrence that is not well defined in this specific setting of fertility preservation, and that in the past in my practice I have sent patients for additional treatment for that. So, but like I said, we may be over treating. It's an area with very little data.
Thank you.
And how would you approach the fertility-sparing treatment for the endometrial cancer in the isthmus or lower uterine segment?
So, in general, we have not used the topography or the location of the endometrial cancer as a line of this is a absolute contraindication. Most of these patients usually have endometrium limited disease, hopefully focal disease, not extensive disease. We have not used the topography to say this is an absolute contraindication.
So, thank you. Lastly, I will ask about low-grade serous ovarian cancer. These are young patients. But how about for those having over stage 1C1 disease? Is there any chance to preserve fertility in these cases?
So it's a very good discussion, and there are again a couple of schools of thought and disagreements. So some colleagues are more accepting of fertility preservation in the setting of invasive implants in the peritoneum, in the setting of a borderline tumor. For us in our practice, once you have invasive implants in the peritoneum, we call this low-grade serous. And once you have low-grade serous in the peritoneal cavity, we do not see an opportunity for fertility preservation. These patients are at high risk for progression, recurrence, and even dying from the disease. So patients who have peritoneal disease, low-grade serous, or invasive implants that really basically now puts you in low-grade serous, in using our understanding of the process, we don't see an opportunity for fertility preservation. However, there are excellent colleagues and real experts like Professor Philip Maurice, who has another good argument that not all of these cases are the same. There may be patients with borderline tumor with invasive implants who may be managed very carefully by expert centers. So it's an area of some disagreement. In general, we've said if you have invasive implants, you're now low-grade serous, and if it's in the peritoneal cavity, I think patients should be treated with standard complete resection and probably adjuvant systemic therapy.
Excellent. Thank you for the great answers. I've learned a lot.
Thank you.
Me too, Samir.
Nice to meet you.
Thank you so much.
Thank you for taking the time to do
Pleasure.
it.
Thank you both. Thank you.
Thank you so much for watching.